Diabetes is a growing problem here at home, with almost 4 million Filipinos living with the disease. But awareness and better management of its complications can help them live healthier as well as happier. One of the complications is diabetic retinopathy. It happens when high blood sugar levels lead to damage in the eyes, and it typically causes mild vision problems at first. But it could eventually lead to blindness if not managed properly. On the program today, we'll talk more about diabetic retinopathy, its symptoms, types, prevention, as well as treatment. I'm Dr. Freddy Gomez, and welcome to MedTalk Health Talk on CNN Philippines. One in 3 people living with diabetes have some degree of diabetic retinopathy, and every other diabetic and even pre-diabetics are at risk of developing this. Taking active steps to manage it as early as now can help prevent complications and improve your overall health. So let's welcome our guests for today. With us is Dr. Ricardo Papa. He's an ophthalmologist and the Vice President of the Vitreoretina Society of the Philippines. We're also joined by Dr. Lizette Lopez, who's an internal medicine specialist from the UST Hospital. I'll start the discussion with Dr. Rob. Let's talk about what happens when someone has diabetic retinopathy.
People with diabetic retinopathy, there hardly are any symptoms. So that is actually the dangerous part, because the patients, they think everything's going fine. And then later on, when they start to develop the complications of diabetic retinopathy, that's when they start coming in. And by that time, sometimes it's very difficult to reverse the changes that have happened. So that's why our advocacy is to screen early, to catch it early, and to treat it early, and prevent the complications of diabetic retinopathy.
Dr. Lizette, how does someone develop diabetes? Let's explain that to our viewers.
Diabetes, it's a complicated disease in a way. So what happens is there's 2 insults. Generally, there's a genetic component, but not always required. And then we have the lifestyle part, which a lot of people are familiar with, wherein if we have the poor diet in terms of higher sugar intake, yung mahilig sa chocolate, ice cream, and all of that, as well as the carbs. So in Asia, especially in the Philippines, we like our carbohydrates. We have it in our drinks, we have it in our rice, we have it in our everything, in the food and the desserts and everything else. That is a big factor as to why there is a high prevalence of diabetes in our country.
Dr. Rob mentioned that during the initial phases, the symptoms are very mild or hardly any symptoms at all. But are there any red flags, Dr. Rob, that our viewers, especially our viewers with diabetes, should watch out for?
They can have perfect vision, but there are changes already happening. So if you do get symptoms, these symptoms can be very mild. You can have blurring of vision, slight waviness of vision. You can have floaters. Floaters are these black spots floating in the field of vision. So any small changes like that, but they are non-specific, meaning these changes or these symptoms aren't specific to diabetic retinopathy. They can indicate any sort of retina condition in the eye. So when they see those, they should immediately go to their ophthalmologist.
Dr. Rob, what other factors aside from having diabetes can contribute to having a more severe form of diabetic retinopathy?
When we have diabetic patients, I always tell them, you have to go to your cardiologist or endocrinologist. You have to manage, aside from your diabetes, aside from managing the blood sugar, you have to manage your blood pressure, you have to manage your cholesterol levels, because it's been proven that if these are elevated, the progression of retinopathy will also be faster.
Now, Dr. Lizette, we have generally 2 types of diabetes, either type 1 or type 2. Now, for diabetic retinopathy, are both of these, either type 1 or type 2, people at risk of developing diabetic retinopathy?
It has to do with the pathophysiology, or the cause of the diabetic retinopathy is because of the high sugar. So whether they have type 1 or type 2 diabetes, then they can have diabetic retinopathy. For type 1 patients, we generally tell them to get the screening or to get their eyes checked with the ophthalmologist 5 years after the initial diagnosis of type 1 diabetes, because it presents immediately. So people would go to the hospital once they have the symptoms, and that's soon after the disease starts. For type 2 diabetes, because generally people may have it for a while, for years, without really feeling it or without knowing that they have diabetes. So the moment it's diagnosed, we tell them to get screened for diabetic retinopathy already.
The longer a person has diabetes, the more likely they'll develop diabetic retinopathy. Dr. Rob, there are actually two types of diabetic retinopathy. Could you explain this to our viewers?
There is the non-proliferative type, which is the earlier type of diabetic retinopathy, meaning a lot of times these patients will not have any symptoms at all. And then there is the more serious type, which is the proliferative type of diabetic retinopathy. And this is the type wherein the patient will start to develop new vessels and is at risk for developing hemorrhage. So meaning immediate, there will be blurring of vision, sometimes blinding vision, and a lot of times these patients will sometimes need surgery for management later on.
How can someone prevent this? Because that's what we want to achieve here. We don't want it to reach the severe type or even the proliferative type. So what's your advice to our viewers?
Screening is the most important thing. A number of times I do get patients who have been diabetic for a long time and they don't know that they have to have their eyes checked. We do get a lot of those patients who already have the complications of diabetic retinopathy and they haven't had any eye exam at all. So aside from the screening, they do need to control those risk factors like your blood sugar, the blood pressure, and cholesterol, as mentioned earlier.
Now, if proliferative diabetic retinopathy is left untreated, it can lead to serious complications. And we'll talk about what these are when we return. Stay with us on MedTalk Health Talk, your partner in healthcare. This is CNN Philippines. I'm Dr. Freddy Gomez and welcome back to MedTalk Health Talk. When you're living with diabetes, complications may develop over time. For one, diabetic retinopathy is a potentially blinding eye complication, and early detection, as in most diseases, is key. Now, Dr. Liz, going back to diabetes, aside from this diabetic retinopathy, which of course we want to prevent, there are other complications in other parts of the body which diabetes can actually do. What are some of the more severe cases if diabetes is left untreated?
So we have the complications for the microvascular disease, and that's the eye, so the retinopathy, which we're talking about now. We also have, which most people are familiar with, for the nephropathy, or those who will require eventually dialysis if it's not treated. So the kidneys are affected. And then we have the nerves, and that's actually very common as well. A lot of our patients say tusok or some numbness or thickening of their hands and feet, and that's the neuropathy. What most people are not aware of is that even the nerves for the internal organs are affected. So there's the problems with the heart, wherein the blood pressure may fluctuate. There's also problems with constipation, with prolonged food in the stomach. For the more severe complications, we have the amputation because of problems in the big vessels going towards the feet. And therefore, there's also the problem with poor wound healing. And then, of course, we have the strokes and the heart attacks because there are problems already with the blood vessels in the heart or the blood vessels going towards the brain.
Going back to Dr. Rob. Dr. Rob, so it can be hand in hand. Someone with diabetes can not only have diabetic retinopathy, but other factors in their body as well. But focusing on the extreme side of diabetic retinopathy, you talked about some hemorrhages. What will the patient feel kapag malala na yung kanyang diabetic retinopathy?
The main thing is really blurring of vision. So you can get macular edema, and then you can also get vitreous hemorrhage and something known as tractional retinal detachment. So a lot of the symptoms there are basically blurring of vision. If you get blood in your vitreous area, so the vitreous is this gel which is normally clear, and when that fills up with blood, it will cover your view. So the doctor cannot see inside to check the retina. The patient can't see out of his eye to see anything else.
Dr. Rob, many people might be asking if they reach this point and they do lose their vision because of those factors, which one here are reversible and which ones are permanent?
Both are reversible. So when you have macular edema, there are various treatments that we can give. You can give injections of a medication. You can give laser. For vitreous hemorrhage, you can do surgery if it's not clearing after a certain period of time. When you talk about being reversible, sometimes if the macular edema is there for such a long period of time, it's very difficult to reverse. And that's what I was referring to earlier when I said that prevention is always better than cure, because when you get these changes, it's very hard to reverse the changes. So we can clear the blood, but if there's damage that happens to the macular area, it's very hard to bring the patient back to his normal 20/20 vision. So again, if you're watching, please get yourself screened if you haven't already.
Dr. Rob, I'd like to also talk about a very common eye condition that a lot of our viewers know about, and that is glaucoma. Could you talk about the link between glaucoma and diabetic retinopathy?
So glaucoma is a condition wherein the optic nerve of the eye is affected. It's caused by a series of changes in the eye, and most common of which is the rise in intraocular pressure. So the eye has a certain pressure level, and if it rises beyond the normal levels, the optic nerve becomes choked, blood cannot flow very well to the optic nerve, and eventually it dies. So the link between diabetes and glaucoma, it's usually the end stage. So when you have a lot of proliferation of these new vessels, they will block the angles in the eye.
Dr. Liz, I'd like to go back to diabetes ulit para doon sa mga hindi aware, because it's very easy to not know na diabetic ka na pala or pre-diabetic ang isang tao. What's the best test for someone to undertake to know their glucose status?
It should be, the screening is for the fasting blood sugar, so that's an 8-hour fast with no fluids and nothing, no
Yes.
food, of course. And then also an HbA1c, although we have to make sure it's a good quality HbA1c, because there are a lot of laboratories which may not have the best quality HbA1c.
Okay.
The fasting blood sugar for normal is less than 100. For 100 to 125 is the impaired fasting glucose or yung papuntang diabetes. And then 126 and above is diabetes. And for the HbA1c, it is less than 5.7% for normal. And then pre-diabetes is 5.7 to 6.4%. Above 6.5% and above is diabetes.
Dr. Rob, let's talk about screening now for diabetic retinopathy. Explain to our viewers what this entails. A lot of our viewers would like to know, is this painful? Is this tolerable? Tell them how it goes.
When you have an appointment with your ophthalmologist, they will do the basic examination. They'll check your vision, check your refraction, check the pressure of the eye. And one of the final examinations that they do is they dilate the pupil. So the pupil is this black hole in the middle of your iris. So normally it's small, it's about 2 to 3 millimeters. So we will place drops in the eye to dilate it to about 8 to 9 millimeters. And this allows us to see the back part of the eye, which is the retina. So it's not painful, but you will get a lot of glare when you go out. So we tell patients that you will have a hard time reading near objects because you cannot accommodate. And 2, you will have difficulty if there's bright light out. So you will have a lot of glare. So wearing of shades will help out. But definitely it's not painful.
When it comes to these screening tests, where should our viewers go for the most accurate results?
Any ophthalmologist should be able to do that. If you tell them that you are a diabetic and you want to have your retina checked, or even if you just tell them that you're a diabetic, most of them should know enough to do a retina exam. So some of these major hospitals, they will take a photo of your retina, and this, once it gets read, it will indicate there if you do have changes from diabetes or not.
Apart from regular screening, managing diabetes is an effective way to prevent diabetic retinopathy. We'll talk about the best practices when we return. We want to be your partner for a lifetime of good health. So stay with us here on CNN Philippines. One of the more common complications of diabetes is diabetic retinopathy. Today, we're talking about how to avoid, manage, and treat this condition. I'm Dr. Freddy Gomez, and this is MedTalk Health Talk, where your health always comes first. Sometimes diabetic retinopathy can't be prevented. Symptoms often don't appear until the condition progresses. And we mentioned that regular screening is key in preventing severe vision loss. But a healthy lifestyle needs to come hand in hand. Dr. Liz, can you share with our viewers some of the best practices in managing someone's blood glucose and trying to keep it in that very healthy range?
Always the diet and the exercise still, so aside from the medications. Actually, I tell patients the most important part of the management is diet. So if they don't eat properly, then what happens is the medications will either not work very well or you just keep going up on them and then they end up on insulin. So the diet part is so generally that eat more vegetables first, non-starchy vegetables, right? So the more of the leafy ones and yung mga ampalaya and things like that for half of the plate. And then 1/4 of the plate is the just the carbohydrates, and that includes the starchy vegetables. And then we have the proteins at 1/4 of the plate. And the drinks, that's what we should really tell patients, like avoid all sugary drinks as much as possible. Okay. Then we have the exercise or the lifestyle part. And the general rule is so moderate intensity exercise. It used to be 150 minutes per week. So that's around 2.5 hours a week, split up like every 2 to 3 days. However, what happens is that these days, because of the pandemic and people are unable to go out, the guidelines have increased to 200 minutes of moderate intensity exercise. High intensity exercise is 75 minutes per week, and that's if they can't even talk or they can barely talk or just in phrases. So they really should have that sort of activity.
Now, Dr. Rob, I'd like to go to treatment when it comes to diabetic retinopathy. Let's start first with the non-proliferative type. What is the general treatment for this?
So for non-proliferative, it's basically observation. We tell the patient, the most important thing you can do is go regularly to your endocrinologist because we need you to control all those risk factors, the blood sugar, the blood pressure, the cholesterol. And they usually just follow up with us once a year if there are none or there's no retinopathy or if there's mild retinopathy. If the retinopathy is around moderate, then maybe we see them every 5 to 6 months. So if it's not that severe, it's just observation.
Now, what's the prognosis for these types of procedures, Dr. Rob? How likely are they to regain their vision if they indeed have lost a certain percentage of it?
So the prognosis is usually dependent on how affected the macula is. So it can range from anywhere from 50% lower to 100%, especially in those cases where the macula is not affected at all. So if you have traction, when you say traction detachment, when you have proliferation, when you have blood, eventually the blood settles down. It forms membranes over the retina. The membranes can pull, and from being an attached retina, it gets pulled and it becomes detached. So if the macula is detached, the prognosis is guarded, meaning we don't know if the vision will return even if we put the macula back in place. So the patient should be wary if the macula is affected.
Dr. Rob, how often should people or diabetics screen for diabetic retinopathy?
Type 2 diabetics, they should see an ophthalmologist right away. Why? Because we don't know when their diabetes started. It could have started. Sometimes they tell me, Doctor, I was diagnosed with diabetes yesterday, but when I look into their eye, I already see proliferative retinopathy. And I tell them, your diabetes has probably been in there for about 3 to 5 years. So immediately when they are diagnosed as diabetics, they should see an ophthalmologist right away.
Thank you, ophthalmologist Dr. Ricardo Papa and internal medicine specialist Dr. Lizette Lopez for sharing with us your insights. Here on MedTalk Health Talk, we hope to give you the knowledge and care that you need. I'm Dr. Freddy Gomez, and we'll see you again next time. Stay safe, everyone.